Okay, so we're going to finish up the skeletal system by talking a little bit about articulations, which are joints. I don't test you on individual specific types of joints like these. I'll introduce you to them, but I won't test you on these types of synovial joints on 9-6. Now, the categories of joints, the structural classifications of joints is important. So basically, a joint is a place where two bones come together. They're not all meant to be wiggly. I know we're in the habit of thinking of joints associated with our limbs, but the sutures in your skull are also joints, and they're definitely not meant to be mobile. So basically what you have when you're talking about joints is a trade-off between stability and mobility. The more stable you are, the less mobile you are, right? So the sagittal suture right here is meant to be very stable. It's where two bones come together, but relatively immobile. The mobility that you get, for instance, with the glenohumeral joint, which is the shoulder, it has mobility in a bunch of planes. It can go anterior, posterior, lateral, medial, and a lot of things in between. That is really the most mobile joint in your body, and it's also the least stable and the most likely to be dislocated. Okay, so if we look at the categories of joints as we sort of run into them, the ones all the way down at this end are going to be called the fibrous joints. They're not supposed to be wiggly. And the ones all the way down at this end are going to be called the synovial joints. They are supposed to be wiggly. And then you'll have some things in the middle that we'll talk about. Okay, so let's talk about fibrous joints, the mostly immobile joints that you have that you may not even think of as joints, but they definitely are. So what a fibrous joint has is bone, usually some kind of ligaments, and then other bone. There's no cartilage there. There's no fluid there. There's nothing really in there. And if it's a suture like that one, it also tends to be like have interlocked serrated, meaning that if somebody hit me on the back of the right side of my head, the bones of the right side don't slide forward and slice my brain in half, which is, ideal. So as far as categories of these, a suture is a good example of a fibrous joint. And then there are some others that you may not think of as joints. There's also called a gomphosis, which is the joint that actually attach your teeth, which are bony, not bone exactly, to the alveoli of your maxilla and mandible. And it's just got these little periodontal ligaments that are holding them in. And then this one's kind of strange. The radius and the ulna, between them, they have what we call an interosseous membrane. It's basically some dense connective tissue that keeps them the same space apart from one another, but it's not cartilaginous. So they can kind of rotate around one another, but they don't have much wiggle other than that. So those three are all fibrous joints, just bone, connective tissue, usually ligament, and then bone. The next category of joint that we have is called a cartilaginous joint, and a cartilaginous joint goes bone, cartilage, bone. If it is bone, hyaline cartilage bone, it's called a synchondrosis. Synchondroses is plural. And if it is bone, fibrocartilage bone, it's called a symphysis. Symphyses is plural. So let's give a couple of examples of each. The costal cartilages that connect your ribs to your sternum go bone, hyaline cartilage, bone. So they're a synchondrosis. Actually, technically, your epiphyseal plate is a synchondrosis as well because it goes bone, hyaline cartilage, bone. It's a little wigglier at that point, not super wiggly. Definitely, these are wigglier than your fibrous joints. And then the symphyses, you've heard of the pubic symphysis. It's where your two pubic bones come together. There is a pad of fibrocartilage in there, so that is a symphysis. But also the intervertebral discs between your vertebra, that goes bone, fibrocartilage, bone. So that's a symphysis as well. So these are wigglier than the fibrous joints, but they're not the most wiggly joints. The most wiggly joints we have are these guys. All of these joints usually associated with your limbs, not exclusively associated with your limbs, but almost all of these are what we call synovial joints. And synovial joints have a different pattern. They go bone, hyaline cartilage, fluid-filled cavity, hyaline cartilage, bone. Okay, so let's look at what we're seeing here. Notice that we've got compact bone around the outside, and this is spongy bone. Anybody have any idea what you're seeing right there and right there? What are those? Those are the epiphyseal lines where your epiphyseal plates used to be. So in this picture, this person is probably fully grown. Okay, so they have a capsule that's filled with the synovial fluid, and what happens is these are your wiggliest joints, and instead of the cartilage rubbing against the cartilage or the bone rubbing against the bone, there is this viscous fluid that actually lubricates and nourishes the joint cavity, and we'll talk about it in a little bit more detail in just a second. So they do have hyaline cartilage in them, but that's not all they have. Okay, now, this is the thing that I don't generally test you on, this figure right here. There's a whole bunch of different types of joints, depending on how they actually move. We can acknowledge that my elbow moves differently than my shoulder, and my fingers move differently than either of those. So looking at how joints actually move is kind of interesting. Here is, can you tell what that one is? What joint that actually is? They had a radiologist who actually did videos of these, which I think are so cool. How about this joint? Do you know what that is? So that's the elbow, this one, which is a classic hinge joint. And you can get into more detail about it. I don't make you identify these. I just think these are kind of cool, so you might like to see them. Anybody know what this one is? I mean, it says at the top, but don't look. This is kind of your cheat version right there. That's the knee. And then this one's exceptionally cool. That's the hand radiology. So you can go into a ton of detail about how joints actually move and work, but I don't have time to do that. So if you guys go into PT, you'll learn more about it than I ever did. Okay, so I want to look, though, at not all of the synovial joints, but the structure of an individual, one example synovial joint, so that you can see how they work. Okay, so this is any synovial joint. It doesn't really matter which one it is. So let's look at it in a little bit more detail. Okay. So what are we going to see? So at the end of each bone making the synovial joint, there is what we call articular cartilage, and articular cartilage, again, does not mean the type of cartilage tissue. It means it's the cartilage that was forming the joint. In synovial joints, you are most likely to find, almost always, you're going to find hyaline cartilage, okay? So it's hyaline cartilage and has no perichondrium around it at the end here. It's still left over, by the way, from ossification. And then there is this joint cavity, which is the space between bone 1 and bone 2, okay? And the joint cavity is filled with fluid. And the joint cavity is lined on the inside, this purple right here, with what we call a synovial membrane. And the synovial membrane is actually responsible for making the fluid and then dumping it into the joint cavity. It's actually a weird tissue. It's kind of like a loose connective tissue, but it's got secretory capacity. It covers any internal surface inside the joint cavity not lined by cartilage. And it secretes this fluid. But then the outer layer of the synovial membrane around here is made of dense irregular connective tissue, and the dense irregular connective tissue weaves into bone 1 in the periosteum and weaves into bone 2 in the periosteum. So the periosteum, I don't know if you remember, is made of dense irregular connective tissue on the outside, and so if you weave the dense irregular connective tissue of the fibrous layer of the joint capsule or articular capsule into the periosteum. It's a really strong association. It's really hard to pull them off one another. Kind of imagine taking one of those really long soccer socks and pulling it all the way over your knees so that it's really tight on either side. That's kind of how this fibrous part, the outer part of the articular capsule works. And then the fluid that's in here, right, is synovial fluid. Its function is a couple of things. It fills the cavity, of course. It also bears the weight so that bone 1 is actually not sitting directly on bone 2 because it's sitting actually on the fluid. And the fluid is viscous, like thick fluid. And so if you've ever hydroplaned in your car, you know that if the viscosity of the fluid is just right and water's just right, you can actually not make contact with the pavement. Your car can be completely supported by the fluid. That's kind of the idea with synovial fluid. In addition, it's a lubricant and it minimizes friction. And the fluid itself is responsible for nourishing the cartilage in the joint cavity. And then, although they're not drawn on this picture, I'll just scribble some in here. Inside, I'll just draw them in blue. Okay. Inside here, you may have ligaments that go one place to the other. Okay. And that helps to reinforce the joint inside the joint cavity, connects bone to bone. And it's just dense, regular connective tissue, and it's helping to reinforce the joint. The joint would also be strengthened if there was a muscle that had a tendon that went from one side to the other. Now, that's not inside the joint cavity, but let's imagine that there's a muscle here. Hold on. A muscle here that its tendon inserts down here. Then as this muscle gets stronger and stronger, what happens is it reinforces the joint. So it helps to strengthen the joint because the muscle around it is stronger. Now, it's not actually inside the joint. It's just helping to reinforce it. So in addition to all of this, if this were the knee, and I don't think this picture represents that it's supposed to be the knee has 2 extra pads here and here. Those are fibrocartilage pads. And the knee, it needs to be really strong as we became bipedal organisms. The lateral and medial meniscus, plural is menisci, are helping to reinforce, and they're in addition to everything else. So the lateral and medial meniscus would be on the side there. In addition, inside lots of your synovial joints, you have fat pads inside the joints. Okay. Let's see. I want to also go through arthritis, so I'm just going to do this, and then this will be the last video of the skeletal system. All right, so let's talk about some arthritis. The name arthritis, and this is a clinical connection as well, is just inflammation or degeneration of joints. We typically associate the word arthritis with aging, but not all types of arthritis are associated with aging. First, there are acute arthritises, and chronic. And the ones that you usually think of are chronic. But there are some acute infections that can cause arthritis. Lyme disease is one. If it gets in your joints, it can cause an acute inflammation. TB, tuberculosis, can get inside your joints as well. And then a rheumatic fever, which I had when I was a kid, actually can cause some acute joint damage as well. But the ones that you are used to thinking of are like osteoarthritis. Osteoarthritis is the typical wear and tear or aging arthritis that people tend to get as they age. This is a picture of osteoarthritis, and this is also osteoarthritis. What happens is as you age, and especially at joints that receive a lot of wear and tear, a lot of use, you get degeneration of the articular cartilage, especially the articular cartilage in your synovial joints that are going to move a lot. If you remove this cartilage, then the bone will push against the bone. And first it's just inflammatory, but then later on you can actually have the bone thickening. So why does this occur? Well, As you age, you tend to have poorer circulation. And in addition, your collagen that was in your articular cartilage tends to break down as you age. So there can be kind of a genetic predisposition to osteoarthritis. It's not like you inherited it, but you may have inherited slightly less collagen in your articular cartilages than other people. And then if you have a lot of wear and tear, in addition to that, you're more likely to get osteoarthritis. So the exposed bone will eventually thicken. And then this is not just inflammatory. This is actually thickened bone spurs, because as the cartilage degenerates, the bone pushes against the bone. And we know what bone does when bone pushes against bone. So who gets it? Both sexes tend to get it in old age. If you have repetitive use at a certain joint, you're more likely to get it at that joint. So for instance, if you are a tennis player, you are more likely to get it in your elbow. If you're a pitcher, you're more likely to get it in your shoulder. If you're a skier, you're more likely to get it in your knees. So, but where do people get it? Weight-bearing joints, hips, knees, and then your phalanges. These repetitive use joints. And what do they do about it? Primarily just treat the symptoms. They treat the pain, the symptoms associated with it. Usually they start out with over-the-counter medications like aspirin and nonsteroidal anti-inflammatory drugs. Later on you can get prescription strengths of those things, but there's not a whole heck of a lot that you can do for it other than that. Okay, so let's get into a more serious one. More serious one is rheumatoid arthritis. So let's show you guys, not that one. Okay, hold on, I'm trying to find your rheumatoid arthritis. Okay, so rheumatoid arthritis, this is an autoimmune disease. Oops, rotate. Okay, so rheumatoid arthritis is a chronic inflammatory disorder. Your immune system makes a mistake. With an autoimmune disease, it's an immune system mistake. It thinks that, for instance, your synovial membrane is an invader, and it sure as heck isn't. And your immune system attacks your synovial membrane, you stop making synovial fluid, the cartilage starts to degenerate, and then the bone starts to form spurs. The inflammation will cause fluid accumulation and pain. And then over time, because your immune system might not let up, you can get scarring that completely replaces the synovial membranes and the cartilage, and then the damage is permanent. And so this tends to be a progressive disorder. You can see the x-rays here. Here's another x-ray of rheumatoid arthritis as well. The scar tissue, which is replacing the tissue that used to be there, will not allow for normal function any longer, and you get this granulation tissue or scar tissue in the joint. And this tends to be a progressive disorder. Who gets it? All autoimmune disorders are more likely in women. This is not a disease of the elderly. There is both a juvenile form and then this form that mostly women get between the ages of 30 and 40. Where do people get it? Usually small joints first, and for some reason, I do not know why, it's usually symmetrical. So if I get it on my right wrist, I'm usually going to get it on my left wrist. Fingers, wrists, ankles, feet, usually symmetrical. What do? Treat the symptoms primarily. Relieve the pain. Over-the-counter medications probably won't work for very long. Reduce the inflammation by however you can. Eventually, a lot of times they'll use corticosteroids like prednisone to reduce the inflammation here. And sometimes they have to do surgical interventions when the actual changes compromise your normal function. Okay, and then last arthritis is gout, also called gouty arthritis. This one is a weird one. It's a chronic inflammatory disorder, but it's related to your metabolism and kind of to your diet. So when we eat protein-rich foods and nucleic acid-rich foods, you produce uric acid, which is a nitrogen-containing compound from the breakdown, and most of us clear it out just fine. But some people produce too much, and some people actually don't clear it very well, or the combination of the two of them. And so when this uric acid starts to elevate in levels in your bloodstream, for some reason it likes to deposit inside your joints, and it's crystalline. so it crystallizes. So if you have something inside a synovial joint and crystals get in there and then you wiggle, can you imagine how much irritation and inflammation is going to occur? So when the uric acid increases in the blood, it deposits as the sodium urate crystals and it causes pain, big time inflammation. Who gets this one? This one is mostly men, historically speaking, usually middle-aged or older. And they used to say that was primarily because men had higher protein diets. They used to call this the disease of kings because, let's say back in the Middle Ages, who got most of the high protein men, and which men? Rich men. It doesn't have anything to do with sex as far as we know, or even hormones. But protein-rich diets tend to be associated with gout. So that's gout, that's gout, that's gout. Now, it's not like it's going to stay like this all the time, but you can get it and then it will go away and then it will come back and then it will go away and come back. Some people have success with changing their diet. Some people don't. So what do? Treat the pain, of course, and then try to suppress the production of or increase the secretion of uric acid. There's a drug that does that. It's called colchicine. Some people take it and some people choose not to. Okay, last little tidbit here. There are a couple good YouTube videos. They're kind of slow, but they're pretty useful. And then this pop-up via biology is made by a colleague of mine. It's the skull anatomy. She does a stop motion animation that I think is kind of cool. All right, that's it for skeletal system.